Afternoon, ladies and gentlemen. Thank you for being with us again. Today we're reporting 3,174 new cases of COVID-19. There was a technical issue which we've had before with a one-day reporting of cases, so there might be a slight adjustment in that figure when it's corrected, but it'll all be part of the 14, 5 and 7 day instances which we rely on. And there's a technical note in the briefing that just covers it, just so you're aware of that. There were 56 newly reported deaths since last Wednesday, the 27th of October, bringing the cumulative total of deaths now since the outset of the pandemic to 5,492. And as of 8 a.m. this morning, there were 460 patients in hospital with COVID-19 and 86 currently with COVID-19 in the intensive care units. I'm going to ask Professor Nolan now just to take us through Philip.
In brief, what this presentation is going to show is that we've had a very large number of cases reported over the last week through the mid-term break, a reflection of the very high case counts. That's not yet translating into an increase in hospitalisations. In fact, the number of people in hospital seems to have declined a little bit. It's far too early to read anything into that trend, and we just have to watch very carefully over the coming weeks to see if there is a change in the relationship between hospitalisation, between case and hospitalisation. And this is a very strong signal. The virus is spreading at very high force of infection, very high levels, a very strong signal to each and every one of us that we really need to wind back our social contacts to an extent in order to bring reproduction number back towards and be ultimately below 1. Just because of the issue that's been mentioned there, all of the data that I'm going to present is up to and including yesterday's data. So just looking at the moving average case counts, 4 weeks ago, we were looking at about 1,500 cases a day. Yesterday, 7-day average was 2,612, so a very significant increase, and 20% of that, there being a 25% increase between last week and this week. So a very significant uptick, particularly in the last week in the number of cases. Our 14-day cumulative incidence now approaching 700 per 100,000. The number of people in hospital on average over the last 7 days was higher than the preceding week, approaching 500 at 493. It's 460 today, so just over the last couple of days the number of people in hospital has dropped. Of concern in the background, the number of people being admitted to hospital per day is very high, averaging around 60 per day, which is 50% higher than it was 4 weeks ago. Similarly, the number of people being admitted to ICU per day remains high at 6 per day, and close to, on average over the last week, 100 people in intensive care. And again, that seems to have dropped over the last couple of days, so there's 86 people in intensive care today. We can see, if we just look back over the full pandemic, it puts into perspective just how high these case counts are. There's only one point that back in January in the pandemic that we've seen case counts anything like, on average, 2,600 per day. It is, of course, different because of the enormous protection being offered by vaccination, but we also need to keep in mind that level of infection is, given the level of protection of vaccination, represents a very high force of infection in the population and very large numbers of opportunities for the virus to transmit. Many opportunities being interrupted by vaccination, but that number of transmissions nonetheless breaking through. And there's no doubt in my mind, or in IMAG's mind, that this is primarily driven by progressive increases in effective social contact. You can see coming into September, cases were stabilising. We'd had a very large surge in unvaccinated young adults, particularly aged 16 to 40. Now that they were vaccinated coming in just as schools were opening, the vaccination of that cohort stabilised case counts. But from the end of September, you can see case counts increasing, and that increase may well have been accelerated by a very significant increase in social contact in the immediate run-up to and through the school mid-term break. So you can see those 2 points at which restrictions were formally relaxed. That's one thing. but more importantly, in the background, sometimes in anticipation and certainly through those relaxations, we can see in all of our other data very large increases in mobility and social contact, leading us to where we are. And when we look at case counts per week, there were 15,740 cases reported in the last epidemiological week. There have only been 2 other weeks, the last week in December and the first week in January, when higher case counts were reported in any given week in the whole course of the pandemic. So in terms of case counts, in terms of infections, this is an exceptionally high period. It's worth dwelling for a moment on the age-specific incidence, and this is a very busy plot. I accept that. So you're starting with, way in the background there, the very youngest age cohort in yellow, 0 to 4, where there's been very little increase in incidence over the last week. And then as you go through progressively greener and then purple, you're going to the older age groups, ending with those age 85 and older. And the first thing that's remarkable about this is that we've seen, you can see at the top of that, the 19 to 24 year age group are at the highest incidence again, or have the highest incidence again. And you can see that that very sudden increase in incidence is paralleled across all of the other adult age groups. So right from 19 years of age, right up to 75 years of age, just over the last week or 10 days, we've seen a very rapid increase in incidence. I think it's worth noting 2 other things. Towards the very bottom of the chart, in purple, is the incidence in those aged 85 and older. And you can see that despite the increase in incidence across all of the rest of the population, the incidence in those aged 85 and older hasn't increased greatly. It's highly likely that this is due to, at least in part and probably mostly, due to the impact of the recent 3rd dose vaccination, the booster vaccination in those aged 80 and older. And despite the increase in incidence across the rest of the population, these vaccinations are protecting that population against both infection, because they've just been boosted, and severe disease. And I think it is a signal to anyone who's offered booster vaccinations of the value of taking up those booster vaccinations. And immediately above the 85 group, there's a green line, and that green line is cases or incidence in those aged 13 to 18 years of age. And incidence has been very stable in that 2nd level student age group right from the beginning of September. They're recently vaccinated, they're in school, and incidence has increased really quite sharply immediately after schools closed. So again, both in the 2nd level school going population, in particular the senior cycle, and in the 3rd level population, the well-known increase in social contact in the run-up to and during the midterm break has unfortunately yielded a very significant increase in incidence across those groups. And again, it underlines the extent to which we have reason to believe that this progressive increase right through September and now very sharply at the end of October is due to increases in social contact, or in effective social contact. Very quickly then, the demand for testing remains very high indeed. We haven't seen demand for testing at this level since January. And unfortunately, in the red line, you can see a unrelenting increase in test positivity. So the solid red line is the proportion of tests processed in public health labs that are reported as positive. That was around 6% in mid-September, has increased progressively over the weeks, and now is in excess of 15%. So equally, test positivity is increasing across all age groups. Most markedly, interestingly, in those aged 13 to 30 years of age, but right across the full spectrum of ages. So all of that data reflects a very high force of infection in the population, and the infection is spreading because we have all increased our social contact, and perhaps because we are not as attentive to the risk reduction measures in those social contacts. In terms of hospitalisation, you'll be aware that the numbers of people in hospital and the number of people in ICU has dropped in recent days. I think when you look at it in the long run here, right back to the beginning of the pandemic, you can see that it's far too early to ascribe anything to that. It may be because booster vaccinations are offering additional protection to older and immunocompromised people. It may be a further shift in the age mix. We're beginning to see more cases in younger people as a proportion than we did 2 or 3 weeks ago, or it may simply be one of those transient things that occurs around bank holiday midterm periods. We did see this this time last year. So 460 people in hospital today, but of concern, the highest number of admissions per day that we've seen in some time, on average, in or around 60 admissions per day. Similarly, in intensive care, the number of people in intensive care dropped slightly over the last week or so, the number of admissions per day remaining constant, and the number of people requiring mechanical ventilation constant. The number of deaths per day also, fortunately, constant. We are concerned that this might rise, is likely to rise in the coming weeks because of this very large burden of infection that has evolved over the last 2 weeks. That said, those booster doses are going to offer an important cohort of the population additional protection. So the relationship between cases and mortality may be changing as we speak. Formally then, yes, the epidemic continues to grow really quite rapidly, with estimates of growth rates somewhere between 2 and 3% per day for cases and around 1% per day for hospitalizations. So in summary then, incidence very high and increasing, very high force of infection in the population. Growth rate, as I say, 2 to 3% per day for cases and 1% per day for hospitalizations. In terms of cases or the growth of infection, that corresponds to an effective reproduction number around 1.4, 1.5, and I'll come back to that in a moment. As I said, this is very clearly driven by increased social contact and a reduction in the mitigation of risk during those social contacts. We have that evidence from the social activity measure data from the ESRI and frankly from the evidence of our own eyes. We know that compliance could be improved. The EMORC data tells us, or the EMORC survey tells us that 1 in 4 people attending hospitality over the last weekend were not checked for their COVID passes, and that COVID pass is an essential element in terms of reducing the risk of social contact. And all of our mobility data is showing pre-pandemic levels of mobility are higher than pre-pandemic levels of mobility. So with all of that said, the future trajectory is very uncertain. We've seen this kind of increase in cases during and after school breaks before, but we haven't seen it in this context where we have a very, very high force of infection and a highly vaccinated population. So it's hard to say what's going to happen over the next week or two. There may also be a changing relationship between cases and hospitalizations, but again, it's too early to draw that conclusion. So we are in the situation where we need to bring this force of infection down, and that's a matter for us in terms of managing our social contacts, and it's a matter for institutions and sectors in terms of the supports they offer us to remind us and to support us in managing those social contacts. And to kind of, we are in the territory now saying to people, you need to cut your social contacts individually and voluntarily. If reproduction number is 1.4, if you are planning to see 15, 20 people next week, it would be much better to plan to see 8, 9, 10, reducing the social contacts by 30 or 40% and bringing reproduction number back down towards 1, or equally consider how much more careful you could be in each of those social contacts. So it requires a significant but not enormous effort from each and every one of us to bring the level of effective social contact and the risks associated back towards a manageable level. Thank you.
Philip. Now, happy to take any questions. Zara.
Media. So for the last 2 weeks, the message had been go back to basics. Am I right in saying the new message now is cut your social contacts? Are you hoping that both of those things combined can make a big difference over the next 2 weeks?
We are. I mean, the combination of all of these important measures, they've worked before, and if we can find it within ourselves to, and as Professor Nolan says, maybe not a huge improvement. So it's not as if we think we've seen the population completely abandoning all the public health measures. Indeed, a lot of the suppression of the infection that we see at the moment, and I made this point last week, coming from both vaccinations and the high level of compliance with the public health measures, has brought a reproduction number down from something like 6 to 8, which is what it would be if there was no suppression whatsoever, to something in the order of, as we hear, perhaps 1.4. We need a little bit more, and it's going to be the combination of all of those basic measures. Perhaps it isn't what everybody wants to hear. It's not what I want to be telling people, but it is important. We know it works. So all these basic measures that people can take at an individual level to protect themselves, the basic measures around respiratory etiquette, mask wearing, and social distancing. And that will mean cutting contacts and thinking a little bit and being more mindful of the plans that you have over a period of time, over the next week, over the next 2 weeks, to kind of ration, if you like, the kinds of discretionary activities that you might undertake. And if it is a thing, as Professor Nolan says, so you're planning to have a number of people over to the house, maybe it's a smaller number of people. Those kinds of measures, additively, will have a significant impact, we hope, in terms of reducing transmission. And a message that we've issued in the past, that if we can have most of the people observing most of the measures most of the time, and we can all be mindful of that, that can make a significant difference. We have seen a significant shift in hospitalisation, in socialisation, I should say. If we can just can we easily pull up the slides on activity? Just to make this point to you, you'll have seen these graphs before, so the next slide I think will have some of the data that I'm referring to. I can talk through it. If we look at the Google and Apple mobility data that we rely on, and that gives us an assess here, this is the one that shows retail and recreation. It's the Google data. The black line running across the middle is the pre-pandemic level of socialisation. We touched on that in the week running into Christmas last year. We touched on it in the summer when incidence levels were much, much lower than they are now. And we've now exceeded that. And this is the highest level of socialisation, at least as measured by that we've seen in the entire pandemic. And of course, we know that this is the explanation behind such widespread, every age group, every part of the country, every social setting. That transmission can only be explained by such a widespread increase in socialisation. And we need to dial that back. And so each one of us needs to be looking at our own adherence to the basic measures to protect ourselves, as well as the plans that we have in terms of engaging with other people, social contacts, and in particular, again, to emphasise the point that we made last week. If one is engaged, there are high-risk activities, and we know what they are, available to people, because society is fully open, and for people who have and can demonstrate immunity, can have access to nightclubs and pubs and all of those kinds of things. So if you're planning to meet up over the course of the coming weeks, in particular with people that you know to be vulnerable to the severe effects of this infection, it's best to avoid that if you've been involved in high-risk activities for a period of time. So it's being mindful of the importance of each of these basic measures and reminding people around that. That's what our message is. So it's not a change message. It's just keep up all of the basics.
Would you appreciate, though, Dr. Hoolan, that there might be people kind of watching this at home who might say, is this what the future looks like for us in terms of, what life is going to be like? Are we going to go through surges where there's just is that what endemic kind of looks like? Is this sort of the reality that we have to accept and get used to moving forward now?
That the force of infection is a very important factor in all of this. We have really, really high levels of infection. So very small changes in socialisation will produce a big effect in terms of the numbers of disease, the numbers of cases that result from that, and that's what we're seeing at the moment. If we're at a more controlled and lower level of transmission, yes, which is where we want to be, and if we can get there, being in a position then to spot small, localised changes in the incidence and responding to those as quickly as we can, and putting in place measures to try to limit that becoming established, wider spread community transmission. That's where we want to be. But endemic will mean that even if we get back to lower level of incidence, that we will see a continuing challenge with outbreaks, with surges potentially of the infection, and with this infection still representing a risk, particularly to people who are vulnerable, particularly to people who are not vaccinated. And so we still stress the importance of vaccination. And just as a reminder, although we've done really well in terms of vaccination overall, there are still groups of people where vaccination is not at a level that we would like. So of our 18 to 30 population, approximately 1 in 5 of those are yet to be vaccinated. Of our 12 to 15 age group, approximately 2 in 5 of those are yet to be vaccinated. Within that overall 7% who are yet to be vaccinated. So the 7% can hide the fact that quite high numbers of relative terms, people under the age of 30 are not yet vaccinated, and we know that they're socialising, and we can now see from both the age-specific incidence and the positivity-specific figures we've seen for that particular age group that there are very, very high levels of transmission going on in that age group.
Can I just ask you, Professor Cormacan, just about the school situation? And obviously last week you were talking about the incidence being quite high in the 5 to 12-year-olds. Where are we at with that now? Is there a plan to go back to testing close contacts in schools?
Thank you. I suppose the first thing I'd like to do is take the chance to talk to the children, because we often talk about the children, but we don't talk to them often enough. And I suppose the first thing I'd like to say to the children is thank you. It's been a difficult couple of years, and you've been brilliant. You've put up with a lot, and you've put up with a lot to keep yourselves and your classmates and your teachers and everybody else safe. So I think we all owe the children a big thank you. The second thing is I'd like to say to the children is the numbers we're looking at now is not your fault. It's not because you're going to school. You've been going to school for a long time now. You've done everything that's been asked of you, most of you. You've been very careful. You've kept the rules. We need you to ask it. I need to keep asking you to keep doing that. So we need you to stay home when you're sick. We need you to stay home when there's somebody in your house who has COVID. We need you to do what the teachers ask you in terms of keeping the rules. And what we see from what we see is the truth about your lives to the children is that the least way COVID spreads is for you to give it to a grown-up. The next least way it spread is for you to give it to another kid. The next one is for an adult to give it to you. And the next thing is for an adult to give it to an adult. So you're doing great. Keep it up. Thank you. And what you're doing is working. And at the moment, what's working in schools is working, and we've no immediate plans to change what we're doing in schools. And it's a credit to the children, first of all, to their teachers and their parents that they're making it work. And as Dr. Holland said, we've seen a huge increase in socialisation. That's what's driving the increase, and it's not because children are going to school. They've been doing that for a while now, and the numbers haven't. That's not what's driving this.
I know last week I asked you about a circuit breaker and what would that look like. We're a week on now. Is there any thoughts of what a circuit breaker might look like and if we'll have to implement one?
No, that's not a discussion we're having. I mean, we know that the measures that we're recommending, focused as we are on individuals' behaviour and compliance with adherence to the public health messaging, as well as Professor Nolan has said, across all the sectors, making the environments in which people will spend time, particularly indoor environments, as safe as they reasonably can be. And when we hear that, in the hospitality sector over the course of the last weekend, from the Amoric data, that people are reporting that in 1 in 4 situations they're not being checked for the COVID pass. These are the kinds of basic measures we want to see, and we want to encourage people to do the right thing. And as I said last week, in particular, people who have leadership responsibilities, whether they're running businesses, providing services, or otherwise have influence across society, that they would encourage people and demonstrate through their adherence in the environments that they create for individuals a commitment to the spirit of the guidance that's there. And so through an improvement in our collective adherence and an improvement in the kind of environments in which we're spending time, and each of us being more mindful about how we plan in our social contacts and being careful, if you like, about managing that in a way that limits the risk of transmission. These are the kinds of measures that we think can be successful. We're not giving contemplation at this point in time to additional and wider measures. The reality is that the economic and social restrictions that were in place, not just in this country but in many, many other countries, in a way took the discretion away from individuals about what it is they might do. So if I can just use the pub as an example, if the pub is closed, the decision is made for you about whether you go to the pub. The pub is now open and you can make that decision. But whether you go there and your behaviour in preparation for going there, particularly the importance of if you have symptoms, staying away, we have to keep emphasising that message. That's one of the most critical messages that we have when people have respiratory symptoms. They need to stay home, they need to contact their GP, they need to arrange for a test. and those are still the same basic messages that we're issuing. The pub environment itself, it can be influenced by people who are running pubs to make it as safe as possible, to ensure that the COVID pass and those other protections that are in place for customers and staff are in place. And so we want to see people using these as safely as we possibly can. We think with not necessarily a huge improvement, but an improvement in terms of our collective performance across all those basic measures, that we can reduce the level of transmission that we're seeing with the infection at the moment. That's what our plan is.
Can I just ask for an update on the Delta sublineage? How many cases do we have now?
Just at around 90 at the moment, so we should have more data coming through this week, but it certainly hasn't kicked off since we last spoke.
Oh, so it was the same as last week?
Yeah.
Thanks, Sarah.
At this point, when you're expecting cases to level off and then fall?
Yeah, I think that's a very important issue to address. Understandably, there's a sense out there, and there's validity to this sense, that cases should, at some point in the future, plateau and fall. And why might that happen? Because more people become vaccinated, more people are boosted, and more people who, for one reason or another, haven't been vaccinated may become infected, and therefore the level of immunity in the population reaches a critical level where the epidemic can't sustain itself or can't grow further. But it's very hard to say when. So some of our models, the most recent set of models that we've run, would suggest that that'll happen relatively soon in the course of November. But for instance, an important caveat there is waning immunity, waning vaccine-induced immunity is not built into those models yet. And it's very hard to estimate how many people out there have become infected that we don't know about because they were asymptomatic, undetected infections. And if you change those assumptions, you get a very different profile over the coming months. So it's very hard to say. You know, one set of models shows a peak or plateau developing in late November into early December, and cases declining from that point. But other models show later, longer, higher, and much slower to decline peaks. And it simply depends on the assumptions, and some of those assumptions we simply don't have good estimates for those assumptions. So to cut a long story short, that's an impossible question to answer. It is inevitable that we would, even if nothing else changed, we'd reach a plateau and a decline. And it's for that reason that we have to pull back to the force of infection we have here is simply too high. To the question asked by Zara earlier, unless by our actions we bring down force of infection over the coming weeks, unless everything else is in our favour, we're really going to struggle to control this virus for months to come through a winter.
And the 15,000 cases over the last week, do we know what percentage of them were fully vaccinated or partially?
I couldn't give you a precise figure on that at this point. No.
Okay. Is there evidence of sort of an increasing number of breakthrough infections then? Or?
Well, just be careful with the interpretation of that. There isn't evidence of an increasing proportion of breakthrough infections that would lead you to worry about waning immunity. There is what we always see with vaccination, that as more and more people are vaccinated, more and more of the cases are vaccinated. But the proportion of vaccinated cases is what you would expect, given the protection offered by vaccination and the number of people who are vaccinated. So the very small number of people who are unvaccinated, a very small number of adults, the 7% of adults or so who are unvaccinated, are disproportionately represented in the cases. So 7% of people, 7% of adults are unvaccinated, but close to 30 or 40% of cases are unvaccinated. So there's a big difference there in terms of the protection of vaccination. So we're not seeing any fundamental shift in the proportion of cases vaccinated that would lead us to believe there's something going on in the background. I don't know if Tony or... Okay.
Can you hear me? Yeah, it's working now. That approximately, on a given day, approximately 40% of people who are in intensive care units with COVID could be regarded as breakthrough infections, and the remainder not vaccinated, as in having had the 2 full doses and so on. And so that's a continuing concern. So you have a substantial overrepresentation among the cases, but also among intensive care units, and as we know, among the deaths relative to the overall population.
Okay, you're talking about quite a rapid increase in incidence among 19 to 24-year-olds. We're about sort of 10 days on now from the reopening of nightclubs and a lot of gig venues across the country. Is there anything to suggest that that sort of first weekend has played into the recent high case numbers?
Well, if you look at the timed periods, so over the course of the last 2 to 3 weeks, we've seen a significant change in terms of, probably the last 2 weeks in particular, in terms of socialisation. You can see that in the data I showed you on that. And then you can see a change in the increase in case numbers. It's not confined to the 19 to 24s. They come out ahead of all of the other groups. But we're seeing rising incidence across all of the age groups, as Philip says, up as far as the mid-70s. And the encouraging pattern, and we need a little bit more time and data to know for certain that this is an effect of the boosters. But if you were looking for a positive effect of the boosters, you would see it in a change in the incidence pattern among the age groups where we are seeing that change in the incidence pattern. In other words, the slight levelling in the 75 to 84-year-old age group, half of whom have been in the target group for boosters for some time, and then the over 85s where it's reduced further, particularly we include those who live in residential care facilities. So we've seen an effect there, but in all of the other age groups we're seeing a rising incidence, and it happens that it's the 19 to 24s who come out on top, but by no means is the message that in some way something that they've done around nightclubs is the cause of all of this. There's been a collective increase in socialisation across the entire population. The resultant impact of that is an increase in age-specific incidence right across the entire population, with the exception of the possible protection through boosters of the over 75s, and then a significant shift in that over the course of the last number of weeks that tells us that this isn't about one age group and one particular behaviour, that it's our collective behaviour across every setting and across all of the age groups.
Okay, and then we just heard from an immunologist at DCU today suggesting that free antigen tests be sent to every home in the country. In the UK, they obviously make them freely available to people. Is that something that you'd support?
So in our most recent advice, from an NPHET point of view, we did point to the possibility that now everything is open. There isn't a dependence on something being open by the use of antigen tests in an asymptomatic population. Our concern previously had been, we've articulated it on many occasions, and the data and evidence in this hasn't particularly changed. In a low incidence situation applied to asymptomatic populations, it's not reliable enough. But that's not the situation we now find ourselves in. First of all, everything is open. Second of all, our incidence in the population is high, and particularly high among close contacts. So we've advised in the use of antigen tests in close contact situations. We've asked the rapid testing group to have a specific look, as they have, at the potential use as an add-on. So if somebody is thinking about using an antigen test, it needs to, number one, be an add-on to all of the other measures. So it's not in place of your compliance with everything else, it's an addition. So if you're thinking of, for example, going to a nightclub and you decide to use one of these and it identifies you as a positive and you stay away, that's a further positive contribution to reducing risks if you were going to that nightclub in any case. And that's a key difference in terms of the potential use of them in previous situations before nightclubs were open and people were saying if we could use antigen tests we could open a nightclub that wouldn't otherwise be safe to open. And a key message when we're talking about antigen tests, because they are freely available for people to purchase in many settings, is that they are being used, and we know this, by people to determine whether or not they have COVID, and then a symptomatic person who gets a negative result is concluding that they don't have COVID, which is not a safe conclusion, and in particular not safe in the context of them having continuing symptoms and going on to do other things. So in other words, sending children out of school, I should say, when a COVID test is negative, even though they're symptomatic, or going to work, or going to the pub, or going to wherever it is you may be because your antigen test is negative, know you're symptomatic. The basic message that we have to have everybody hear and understand is that if you have respiratory symptoms, you must stay at home, irrespective, and be guided then by your GP and the result of a PCR test if you're being tested. That's the key test for you if you have symptoms. And as we've mentioned, we just have to look at the experience we've had so far in young children in RSV this winter. We've seen many, many more young children being admitted to hospital with RSV than with COVID. So the idea that all we need to do is do an antigen test if we have symptoms to determine whether somebody can safely, that's very unsafe. So if people have symptoms, they simply need to stay home and be guided by the results of PCR test and what their GP might say.
Yeah, and as you say, it's only one tool, but would you be in favour of, in that example you gave, someone thinking of going to a nightclub or a pub, they're doing everything else, and they're thinking, I'll take an antigen test as well. Would you be in favour of, free tests being sent to every home in the country so they have that option as an extra safety precaution?
We haven't advised in relation to that particular issue. I think the concern is that if people don't fully understand the circumstances, and the issue with antigen tests has always been not about do we use an antigen test or not, but when are the appropriate circumstances? There have always been appropriate circumstances for antigen tests to be used. But in a widespread situation where they're widely available, there's a real risk, because I think there is a substantial amount of public confusion about antigen tests, that they get applied in circumstances which they shouldn't be applied, used in situations where people are symptomatic, and other circumstances as I've outlined. We haven't given specific advice that they should be made widely available free of charge.
Okay,
but they are widely available in many settings, and hence the reason we're giving that basic advice to the public about how to appropriately use them.
Thank you.
Thank you.
Good evening. Can I ask you about the technical issue that affected the numbers reported, I think, yesterday? So yesterday, am I right in thinking we had an artificially low number of notifications yesterday? So does that mean that yesterday's figure of 3,700 plus should probably have been higher? And do you know what it should have been?
And I think most of the effect is related to today's figure. So you're right.
Today's figure.
Yeah. So in other words, so today's figure is an estimate on the basis of test results, which we've done in the past when we had a challenge with the cyber effect. This is, as I understand things, a one-day technical issue which is now resolved. And if we relied just on the CIDR data, what would have happened? We would have a number. We'd have given you a number today which is artificially low, and that number then will be corrected by an artificially higher number tomorrow of the CIDR. And those two will be balanced out actually when we look at the 5-day and the 7-day.
Is today's figure artificially low?
No, so today's figure, the 3,000, I don't know what the precise figure, 33174, I think you can double check that I'm precise in my recollection of that. That figure is an estimate based on the number of tests, and you can take it as broadly, it will be corrected in terms of its precision. But all of this, and we've had these situations before, particularly as a consequence of the cyber attack, where for an extended period of time we used this system of assessment or estimation. And there was a technical issue which I understand was short-lived. It arose yesterday, affects the number that CIDR would have reported today, which is the system we've been using for the last number of weeks. But it's been modified now, or it's been fixed, that issue.
We're not talking about a backlog of cases here. We're talking about a technical issue. It's an important point to get.
Exactly.
We did face backlogs in late December, January last year, and
this is not a backlog issue. It's just a one-day thing, and I understand that it's resolved.
Okay.
And in the 14-day and 7-day reports that we'll be giving you in the coming days, these will all be corrected. And we always, and it's back to just underscore the importance of sometimes we can't rely just on what one day's figures are telling us. There could be reasons why that can vary, and here's the reason why, and we're just being clear and open about that. The issue has been resolved. The reliable data comes from our assessment of what's happening to the 14 and the 7 and the detailed material that Professor Nolan has outlined.
Can I ask you about what Nayak said about vaccine effectiveness for the under 60s? Effectively, that it sustains against serious illness, hospitalisation, and ICU admission, except for people who are immunocompromised at this point. So, would you concur that at this point in time, it's not necessary to give booster vaccines for those under 60?
So that hasn't been advised on yet, but that matter is being kept under continuing review by NAC. As a number of other issues around potential further vaccination. So NIC is continuing to examine the evidence in relation to that, and I'm not at all, so that hasn't happened as yet, but I'm not at all saying
that a reasonable interpretation of what that means, though? Is it reasonable to interpret at this point in time that you could concur at the moment, in terms of what we know at this point in time, that there's no great evidence yet to show a benefit for giving a booster dose to people under 60, except for the categories I mentioned?
Well, that's the reason why NIAC has given the advice it's given so far, and hasn't as yet advised in relation to people under the age of 60, although it has indicated by letter that it will continue to look at the evidence in relation to that point. Obviously, the priority for us now is to focus on those for whom vaccination has been recommended. It's all of those over the age of 60, and it's now also people who work in a healthcare setting. And the HC has a substantial job now to roll out as quickly as we can reasonably do so booster doses to those people in those age groups, while NIAC continues to assess the case for those, and also the case potentially that might arise for others who are not yet the subject of vaccine recommendations. And just to remind you, the EMA is looking at authorisation around the question of primary school age children, 5 to 12-year-olds, in terms of potential vaccination. So all these things are being kept under review.
Professor Nolan, can I ask you, if we didn't have the levels of vaccination, the high levels that we have at this point in time, given what you know, what type of daily cases could we be seeing today?
There's different ways to answer that question, but the simplest way to answer the question is to imagine that just right now we could turn off everybody's vaccine protection rather than going back in time. So, like, if we turned off everybody's vaccine protection now, within a generation time, which is 4 or 5 days, you'd see somewhere north of 10,000 cases a day. And a generation time, if nothing else changed, if everybody freely mixed in society, and 3 or 4 days later, there is no reason to believe you wouldn't see 4 times that again. So they're unimaginable numbers in a way. So it's a very good question to ask, because it underlines this huge job that vaccine protection is doing in keeping a very large number of infections, in interrupting a very significant number of transmissions. And then everybody is reducing their level of social contact to a certain extent and observing basic measures to a certain extent. So that's gaining us a little bit of extra suppression. And that's bringing us from, like, in the wild, this virus has a reproduction number, perhaps Delta variant somewhere between 5 and 8 for sake of argument. If there was no protection in place, any person would infect 5 to 8 other people. So the fact that any person right now is infecting on average 1.4 other people shows you just how much protection vaccination is offering, and the added protection that the observation of the basic measures is offering.
And Dr. Hoolan, I mean, I thought probably the starkest line from today really is that the level of socialisation in the population is at its greatest level since the pandemic began. That is quite a statement and quite a reflection of what's happening out there. And the reason why I suppose that maybe is stark is that we were here about 2 or so weeks ago, and the point was being made that there had been an increase in social interaction, but even small changes in the right direction on that could bring numbers down. But it seems, on the face of it, that people aren't heeding what you said, because if anything, it seems to have gone in another direction. Am I correct?
Yeah, you are correct. And like what we're seeing at the moment in terms of that pattern of socialisation, accepting the limitations, the methodologies that are used to, so this is the Google and the Apple mobility data that we use. We also have the Amoric survey data. But insofar as we rely on those, yes, that's telling us that we're having levels of socialisation that are in excess of those that we've seen at any other point in the pandemic, as measured by those same metrics. So we think they're reliable. And yes, you're absolutely right. This isn't the trend in terms of socialisation that we're looking for, in terms of the message that we're giving out. But we're still continuing to give out that message, because although people are probably sick and tired of listening to it, and in many ways don't want to hear it, and we understand that, we don't want to be giving that message any more than people want to hear it, it is still the set of measures that have worked in the past, the basic set of measures that we need to adhere to. And if I can go back to the kind of the lines of defence that we've spoken about before, the most effective line of defence in terms of transmission of this infection are the behaviours of the public in terms of compliance with, and adherence to all of the basic measures, augmented by vaccination and the boosting of immunity that gives us all. After that, then our system in terms of detection of cases, identification of those cases and resultant behaviour, hopefully people staying out of out of circulation when they're identified as cases. That's our second line through our primary care and public health system. And then ultimately our hospitals and the provision of hospital services and ICU services for those preventable situations where people require and it can only require hospitalisation. We're seeing that line, those two, in other words, the front line in terms of the health service, the primary care, public health system, and then the acute hospital system, and all the other parts of the health system under extreme pressure by any metric as things now stand, because we're just not getting enough protection in that first line. And that's why we keep coming back and stressing the same basic and boring messages around mask wearing, staying away from crowds, avoiding socialisation and being out and about when we have symptoms, the importance of physical distancing, and each of us being mindful about our contacts and trying to minimise them as much as we can, those contacts. These are the things that we each have control of. Thanks.
Gabia Gatavitsgeta from the Irish Independent. Can I ask in relation to antigen testing in schools? So we heard Taoiseach say last week that the government might put in a system where, for example, you have a pod of children at school and there's a confirmed case in that pod and all the other children in the pod are sent an antigen test. Can I ask, is that what you're currently considering at the moment, and is it correct that it would be initially on a pilot basis?
We haven't drawn any conclusions ultimately in relation to that. We've looked at additional measures that we might need to undertake. We've asked ourselves the question, in the context of the transmission levels that we were seeing in school-going age children. Most of that transmission we know is not happening in the school environment. It's happening in the community. It's happening in households in particular. We know that. Are there additional measures that we can take? So we've taken a look, and we're still giving ongoing consideration to the most recently published ECDC guidance in relation to contact tracing, which does have guidance that relates to the school setting as well as many, many other settings, and we're giving ongoing consideration if there's any further changes we need to make to our public health advice in relation to that.
Is that something that you yourself would be in favour of?
Well, it's not just about my opinion. We're giving consideration to this as part of our process, and ultimately may give further consideration to this. We're due to meet next week as part of NPHET, but we have given some initial consideration to that, and at this point in time we're satisfied that, look, Professor Cormacan has outlined the situation in relation to schools, and I might want to add further to what I'm saying, that the school environment itself, through all the good work, we've talked about this on many occasions, are in relative terms, in spite of the very high levels of community transmission, continuing to offer an educational environment which is important for all the reasons that we know, which limits the risk of transmission. But we continually review not just this question, but every question. We get new guidance from ECDC, or we see a change in terms of the patterns of transmission or the age-specific incidents or whatever it might be, and we look and ask ourselves the question, is there something further we need to do? So the fact that we're doing that is not at all out of the ordinary. Professor Cormacan, is there anything you want to add?
Just a small point, and I agree with, as you say, we have to keep all of this under control, but I suppose, under review. But one of the things I suppose we have to ask ourselves is everything we do has consequences, and so if we're going to do that, what is the evidence that it's going to make things better, and what impact does it have on the lives of the children that I was trying to speak to a few minutes ago? What do the children think about this? Because it's really important to think that all of these things impact on the lives of children, whose lives have been hugely impacted already, and they are our future. And we can't objectify them. We have to think about what's good for them. What do they benefit? How does this impact on them? And it's not the greatest thing for many children to go to school to think that they have to have this test done all the time. So should we keep an open mind? Absolutely we should. And if the evidence is there that this makes children and their teachers safer, well, then we need to look at it and we need to say, well, we accept the consequences of that in terms of the unpleasantness. And it is, for some children, this is very unpleasant having these samples taken. We may have to live with that if we see that it protects people. But we would want to know that it's protecting people before we do something that makes the lives of kids harder than they've been already, because the last couple of years have been really hard for children.
Why is getting a child to take an antigen test, how is that objectifying them?
No, if you talk about, I don't mean that that's objectifying. I think we sometimes talk about children instead of thinking what it looks like from the child's point of view. So I'm not accusing you of objective, but I think putting something up your nose all the time, for some children, is very distressing. And so the question is, do we know it's doing good? And if we know it's doing good, and if we have evidence that it's doing good, then I think we have a reason for doing it. But if we don't know it's doing good, we just need to bear in mind that actually for some children, and that'll be very unpleasant. And in some countries where they've introduced this, and very few countries have introduced this for primary school children, but in some where they have, one of the things they've had is that some parents have started to take their children out of school, which is an unintended consequence. Now, you might say that that's the parent's choice, but it's the children. Is it the children's? What is the impact of that for those children in the long term? So I think the key point is that everything that we look at, and I think this is everything that we look at may have an upside and may have a downside. And we need to consider them both. And if there's evidence that it does good to protect people, then we may have to live with a certain amount of downside. But we need to know that it's going to do some good before we accept the downside. That's what I mean about kind of keeping the children in the picture of what they want and what makes their lives good. Because as I say, it's been a tough couple of years for children.
Okay. Can I ask, how long can we keep going with these rising cases before NPHET are going to consider bringing in new restrictions?
Well, as I said last week in relation to that, I'm going to, optimistically regard that still as a hypothetical situation. We still have good reason to believe that measures that we have advised on in the past in terms of the behaviours that we've emphasised over the course of this afternoon are things that we can improve our collective adherence to. And if we can do that, we're hopeful that we'll see a change in terms of transmission. So I don't want to kind of get drawn into a discussion about what I would still regard as a hypothetical situation, that we don't get these cases ultimately under some level of control. But we're not seeing that at the moment, and that's the reason for us raising the level of concern that we're raising.
Is there a certain number that you have in mind in terms of daily cases?
No, there isn't a specific number. As I said, it's the same as it always has been. We look at in the round at all of the measures, both in terms of the incidence, in terms of socialisation, but also then in terms of the impact on hospitalisation and other factors in coming to a rounded decision at any point in time as to what the advice is we should provide.
And then on the flip side of that, then can I ask, if our hospital numbers are kind of remaining relatively stable, then perhaps maybe we shouldn't be as worried about these very high cases?
Not necessarily, because behind some of the data that is there, so we're looking at a relatively more stable, let's say, cumulative number in hospital at a point in time, but that's influenced by lots of things and not just the number of new people being admitted to hospital. If we look at the number of new people admitted to hospital, we see that increasing and continuing to increase, and that's what we expect to see in line with the rising incidence. And insofar as we know that these ultimately are potentially preventable infections, particularly those for the severe cases that require a dependence on intensive care, we think there is more and should do to try to prevent that, because we shouldn't have a recourse to such high levels of ICU admission, such high levels of hospitalisation as a control measure in relation to protecting the public's health from this disease.
Can I just ask Professor Nolan about your modelling? What peak did you expect in November? I believe your last letter, it said the last NPHET letter was 2,000 to 3,000 cases. That's the peak. So isn't it fair to say that we've probably surpassed that and we're only 3 days in?
So again, looking at that letter closely, what any given model, we'll run that model maybe 100 times with slightly different assumptions. And 3,000 was the mean, the average of all of those. But with different assumptions, you get higher numbers or lower numbers. So there's quite a wide confidence interval around those. So what we actually said was it could be anywhere between 2,000 and 5,000. So we're still within the confidence limits, in other words, the range of possibilities that the model showed. And I think the more important thing about those models is to remember all of the other assumptions that I mentioned earlier that are in it. Just because the model shows that case numbers might decline in December doesn't necessarily mean that they will, and there are other possibilities within those range which could see this going on for considerably longer. So this isn't a time to be either pessimistic or optimistic. It's a time to say the force of infection is too high right now. We need to get it down. That high force of infection is creating risks for us into the future. things could go in a number of different directions over the next 6 or 8 weeks. The important thing is to reduce the risk to us as a population by really quite strict adherence to the public health guidance about how we go about our daily business and moderation in our social contacts. Those two things together should bring numbers down, and that's much more important than kind of allowing some hypothetical peak to happen over the next, who knows, 2, 4, 6, 8, 10 weeks, with an ongoing very high force of infection in the population. Because that high force of infection, as I say, things can go rapidly, badly wrong from a high force of infection.
Thank you.
Thanks, Gary.
Simon Carswell with the Irish Times. Dr. De Gascoigne, you'd mentioned there 90 cases of the Delta Plus. I'm just wondering, in your look back so far, just in terms of the age profile, the geographical makeup, and the incident or the severe disease metrics, have you seen anything in the Delta Plus cases that you've looked at so far that would give you cause of concern about maybe the virus is behaving slightly differently with this variant?
But I don't have that data to hand, Simon, to be honest, so I probably better not comment, but I can liaise with the HPSC and send it on to you. That it would be the HPSC that would probably conduct that analysis. They would get the CIDR data that we wouldn't necessarily get at the lab side from the enhanced surveillance perspective, so I can follow up on that for you.
Professor Nolan, you spoke very clearly in answer to Fergal's question there about the effectiveness of the vaccine, and if we were to switch it off overnight, what it would mean. But looking at some of the figures that you had mentioned there, with where the disease is coming, the infection rate is coming down amongst the older groups who are recipients of the booster, does that point to a solution here, essentially that we will potentially may have to look at boosting the entire population as a tool, a more effective tool to bring down case numbers overall?
That's more a policy question, to be honest with you. I think the positive message to be taken out of this is where boosters are necessary to offer protection against severe illness and disease, they very quickly and very clearly offer that protection. It's a much bigger question to ask yourself, are we going to re-medicate an entire population as a substitute for observing some basic public health measures like washing your hands or perhaps wearing a mask on public transport? So that I've no doubt, and other jurisdictions have shown, if you decide to revaccinate the entire population, you will cut transmission. It's a very big policy question about whether that's an appropriate thing to do.
Maybe you'd answer that too as well, Dr.
Yeah, sure. So I mean, the question of boosting, we need to see it in terms, as Professor Nolan rightly says, primarily about protecting the individuals from the severe effects of the disease and maintaining that good benefit that we've seen from the vaccination. And we have good evidence that that is working, and we believe is already beginning to have an effect. And we can see a little of that effect also in terms of transmission, which is what we'd expect from a boosted population if the booster does what we'd like it to do. And that's the primary objective. And that we don't see boosters as a potential control measure, particularly when we're looking at the rising incidence and the speed at which that is changing in all of the age groups, as offering any significant potential in terms of a control measure around transmission. And that linking the two of those, I'm not suggesting your question is doing that now, but they have been linked, that we should simply boost people in order to prevent this level of transmission. As you see in many of the age groups in which we're seeing this very rapidly rising transmission, they're not currently part of our plan in terms of boosting, because we don't believe that as yet the evidence is in favour of that. That may change in time, and behind your question is the potential for that to change. That may well change. In some parts of the world, countries have made declarations that they see themselves boosting an entire population. It's not an unreasonable extrapolation in terms of where our current understanding of the disease, but our current plan, based on NIAC advice, is to focus vaccination for the healthcare workers, but also then those over the age of 60. And again, I'm not suggesting this is behind your question, but I understand a kind of an environment in which there is a hope or a desire on our collective part that there is one thing that we can do. We can find one solution. It might be the antigen test, some magic solution. It might be the booster or whatever in people's minds. Unfortunately, the level of transmission of this disease and the scale in particular of our current force of infection means that we're going to rely and have to rely on every single tool that we have at our disposal, and the collective adherence to all of those, including boosters, including vaccination for those yet to be vaccinated, and then all the basic public health measures. We're going to need every single bit of that if we're going to achieve the turnaround in transmission. And that means an effort from all of us, as I say, most of the people doing most of the things most of the time. I think that needs to be our focus, as opposed to one specific measure that's going to do this for us.
Could I just pick up on one of Dr. Holland's comments there, which is, I suppose, maybe saying something that everybody knows, but I think we would all want to say, is that if you haven't, the biggest concern we have is the people who haven't had any vaccine yet. And if you haven't had the vaccine yet, and if you're thinking about it, we'd love to see you. The door isn't closed. You know, anybody who hasn't had the vaccine yet, if you change your mind, if we can talk to you about, if there's a healthcare provider who can talk to you about whether you haven't had vaccinated yet, I think for all of us, the biggest concern we have is for the safety and welfare of people who haven't taken vaccine yet. Because that's, as Dr. Holland said earlier, that's who we're seeing ending up disproportionately in ICU. That's who we're seeing ending up disproportionately in hospital. It is your choice, but please consider very carefully what it means for you and for everyone else. And as far as the HSE is concerned, we'd love to see you anytime. The door is wide open.
Just final question from me, Dr. Hullen.
Yeah.
I suppose people would see the vaccine, and there was talk before about the vaccine bonus, and people's lives were affected so much for 18 months that they're probably quite keen to cash in on the vaccine bonus and try and get back to some normality. And the figures that you point to in terms of the increase in socialisation probably maybe reflects that. And I guess the question is does the vaccine itself create a false sense of security, do you think, for people? That, well, I've been vaccinated, so I don't understand why I now need to continue to restrict my life as I had been doing.
I think that's a fair point, and there probably is a certain level of improvement, perhaps, in terms of our collective understanding that the vaccine on its own, without adherence to any other measures, is not going to be enough. That's not just me saying this. This is the advice of ECDC, that's looked at the evidence and provided guidance and advice to countries at very different levels of vaccination as to what kind of reliance we will need to have in terms of other non-pharmaceutical interventions. And there's no scenario in terms of vaccine uptake that the ECDC advises no requirement for additional measures. There will always be a requirement for additional measures. And in the collective understanding, I think there probably is room for some improvement of that we're still going to need, particularly at these high levels of transmission and with this high force of infection, to have as strict as we can adherence to some of the basic public health measures that we keep emphasising. And it's understandable that people might feel that, look, have a cold or have these symptoms, had a vaccine, this couldn't be COVID. And unfortunately, that is not true. That is not true. And it's important that people understand that and are open to the possibility that this may well be COVID. We know, and Professor de Gascon can add to this, that the viral loads that can arise for people who are vaccinated can be as high as those who are unvaccinated. And so that potentially creates a risk then in terms of transmission to other individuals. So we need to have that as part of our awareness. That's the science, if you like, and the technicals behind the basic advice that we're given around the measures that people need to take to reduce that risk of transmission.
Yeah, thanks, Dr. Houlihan. I think that's a really important point because there's been a lot of discussion around the viral load and the vaccinated, and I suppose commentary that, well, if the viral load can be the same when I'm vaccinated and I'm not, or if I'm not vaccinated, then where's the point in the vaccine? And I think it's really important that people remember two separate issues. So the first issue is that these vaccines are really effective at preventing against severe disease and hospitalisation, and they're also really effective at preventing against infection. So they're probably about 75% effective against infection over the first 6 months following the vaccine. And what people sort of omit from the calculus is that cohort is not transmitting. So we're impacting on virus transmission by preventing people getting infected in the first place. So then you have the other group that is vaccinated and does get infected. What happens to them? So what we've seen from the data coming out of the UK and more recently from Israel is that the viral load in that cohort is probably equivalent in the unvaccinated group and in the vaccinated. But what's interesting is that the viral kinetics seem to be different. So the rate of incline, the rate of growth in the vaccinated individuals is probably slower, and the rate of decline is probably greater. So even though they have an equivalent peak viral load, they're probably responsible for fewer onward transmissions because they're probably infectious for a shorter period of time. And the data from the UK and the data from Israel would really say the same thing. There's a little bit of a narrative saying that these data are contradictory and that the Israeli data would suggest that the viral load in vaccinated is lower. And actually, they've done a really nice piece of work and a very large piece of work, much larger than the study from the UK. But the study from the UK was about a household transmission study looking at the impact on Delta, and that showed that the secondary attack rate with Delta in a household of vaccinated individuals was less than in an unvaccinated household. Well, the Israeli data suggests that immediately after vaccination, the viral load may be slightly lower, but by about 6 months, that difference is gone. So the viral load is equivalent between the vaccinated and unvaccinated individuals. So just because the viral load may be equivalent if you have been vaccinated, you're probably still less likely to transmit because of the viral kinetics, but equally what we need to include in that calculation is the cohort of individuals that is completely protected and doesn't get infected because they have been vaccinated. So vaccines are still incredibly effective, but they're not 100%. We know that, and we also know from the emerging data that people who are vaccinated can get infected, and people who are vaccinated can transmit the vaccine to other individuals who have also been vaccinated. But again, what we're seeing from the data is that the majority of these transmission events are occurring in the household setting. So if the exposure is prolonged and intense, then the vaccine is likely not to be, or there's an increased chance that the vaccine won't be completely protective. But at the same time, we still know it's very good at protecting against severe disease and against illness because it has primed your immune system for when it sees the virus.
Thanks, Simon.
Hi, Ciara Phelan from the Irish Daily Mirror. Just in relation to 19 to 24-year-olds and their levels of socialisation, a lot of young nurses and doctors are in that age group as well. I just want to know, would you be comfortable with young people that are working in the health service going to nightclubs if you're asking people as well to reduce their social contacts, and if they're caring for vulnerable people in hospital that are either being treated with COVID or are vulnerable with other diseases?
I suppose, obviously, the risk is there that if people socialise, that the virus is going to spread. Having said that, we've asked a lot of our healthcare workers over the last couple of years, and they need to socialise too. So I think what we are asking our healthcare workers to do is to get vaccinated, which overwhelmingly they have done, and to follow good infection prevention control practice and training, which we provide for them, and to be sensible and practical about how they live their lives. But I think given what our healthcare workers have given to all of us in the last couple of years, our colleagues and our friends, and in many cases our families, I think asking them to have no social life is a lot to ask when all their friends are. So I think, follow the rules, good infection prevention control practice, stay out of work when you're sick is their message. Thank you.
I think it would be unfair to target any one particular sector, notwithstanding. And I think that healthcare workers will be mindful of the totality of potential risks and how to influence in the round all of the risks. Which is not to say that they need to stay away completely from certain high-risk activities. We know that higher-risk activities are now possible for people. If you're mindful of that, if you're responsive in terms of, let's say, symptoms that you might develop, you stay out of work in those situations. You follow the basic advice that Professor Cormacan has given. There's no reason why you can't incorporate responsibly a higher-risk activity into your thinking and mindfulness and planning about how you manage your risk overall. And it simply wouldn't be fair to healthcare workers to suggest that in some way or other they should be different to everybody else in the population in terms of that advice.
On pubs, you're saying that the Amárach research is showing 1 in 4 people asked last weekend, was it that they weren't asked for a COVID vaccine? Can you appeal to publicans who may not be adhering to what's being asked of them, or what's your message to them? Because I suppose they're probably feeling that they're having a hard time maybe finding staff, and after the 18 months that they've experienced as well, that it's a tough time for them too.
First thing to say, it's not just pubs. I think that data was pubs but also experiences in restaurants and cafes. So it was
Okay.
across abroad. It was not just publicans, and we're not just focused.
Sorry, you
on-
mentioned pub environment earlier on. So that's
I did, but I'm just making the point that it wasn't confined necessarily to that. And about 1 in 4 people who reported being out and about in those kinds of settings indicated that they hadn't been asked to show their COVID pass. I mean, 2 messages. One is for the people who are responsible for running and providing those services. Yes, of course, we accept and understand that it's been a difficult time for them, particularly given that their services have been under restriction for much, much longer than many, many other parts of society and the economy, and they've had to bear the brunt of that. And we understand the impact that's had on them economically, we understand the impact that's had on staff, and then the questions of availability of staff. So we do understand and are sensitive to all of those kinds of things, but there is still an important message. These basic measures that we're talking about, and no single measure, but the collective measures, and there is good guidance now in place for that sector that needs to be applied, that includes the COVID pass, and that the purpose of those is to protect staff and to protect customers who use those services. And ultimately, you know, to the extent that we can continue to protect staff and customers and services in all settings, we can have assurance about the ability to maintain those services themselves. So it's in the interest ultimately of those sectors themselves to protect their staff and customers now for the purpose of protecting their businesses into the longer term as we deal with the challenges that this infection creates for us. So that's our message to, and the majority, by indication of that data, and we know this is the case, are responsible and are doing their best to try and implement, and that's accorded my own experience as that has been the case. But there are some where the levels of compliance or the existence of measures along the lines of the guidance that I'm referring to are either not sufficiently or in place at all. And that brings me to the second part of the message. It has to be for each one of us as members of the public going out and about, visiting a pub and a restaurant and a cafe, which is a good thing to do, and an enjoyable thing to do, to be mindful of the kind of risk environment. And we know the difference, we should know the difference between a pub, and I'm just using the example of the pub, in which we feel safe. We can see that there's clear adherence to the basic measures, that the hand sanitizers and all of those kinds of things are in place, that the protective measures around the implementation of the guidance are clearly in place, that the COVID pass has been asked for, that people have been asked for their identity to ensure that it is their COVID pass, and all of these should give us all assurance and say this feels to me like a safe environment. It's not overcrowded. Public health guidance is being implemented, versus a pub in which that clearly isn't the case, because that's not a safe environment for you. And people should vote with their feet. And I've said before, I think it is difficult for people to complain. Irish people, I think, have a particular challenge with that in the hospitality sector. But certainly you can take your business elsewhere and not go back to a particular environment where you don't feel safe.
And lastly, just in case I missed it, the incidence rate or the case numbers or positivity rates among 5 to 12-year-olds in comparison to last week, has that increased?
Just in the run-up to the midterm break, so in the week before the midterm break, it looked like the incidence in 5 to 12-year-olds might be starting to stabilise. It was stable through the midterm break, but we know when kids are off school, they're less likely to be tested, and some of them may have travelled. And then, unfortunately, as the disease took off in the course of the midterm break across all of the other adult age groups, that has forced some infections into children. So it's an uncertain picture there, but all of the incidence data at the moment is showing to us that it is the broad mixing in the adult mobile population that's driving incidence into both children and older adults.
Okay. And just for people who are questioning where the data is coming from that proves that there's a low transmission of the disease within schools, can you just elaborate on that? Because some people would argue that we don't have contact tracing, so how could you know?
Well, first of all, the evidence, there's 3 categories of evidence. The first category of evidence is a huge amount of international evidence, and the most reliable evidence is from major systematic reviews, where groups have looked at all of the available studies, brought them together, and come up with estimates of the likelihood of children or adults transmitting. And Professor Cormacan has given you a brief summary of what that looks like. The second form of evidence is that within our own models, we modelled what would happen if children were transmitting as much as adults or not, and we're following the low child transmission scenario. And the third thing is the suspension of testing of asymptomatic contacts in the school setting. That isn't really making a material difference because it was detecting very few cases anyway, and transmissions that were occurring, many of those children would become symptomatic and present for testing through other channels. So all of that evidence taken to, it's not that we would miss it because of this. Actually, that whole operation was detecting very few cases in the first place. So all of that evidence together, and we weren't absolutely certain about this. You know, remember in the run-up to September, we were saying, you know, Delta is a different variant, so we need to see what happens. But since that time, as Professor Cormack said, schools were open for weeks. An instance was coming down actually after an ascertainment spike. So all of that evidence together tells us that the relative risk of transmission in the school setting is significantly lower than the risk of transmission in other social settings, and that in itself is lower again than the risk of transmission in the household, which is where the majority of transmissions are occurring.
Thanks, Ciara.
Hi, Niamh Griffin from the Irish Examiner. Martin, could I start maybe with you? There was a lot of talk about maybe bringing in COVID passes to hospitals to allow to open up for visitors. And I saw the Rotunda, I mean, it was for all hospitals, but the Rotunda, as it happened, put out an announcement saying they're going to implement that. Do you know what's happening with that on a bigger scale?
Yeah, so the NPHET meeting, arising from the NPHET meeting of the 18th of October, there was a decision made about a requirement for COVID passes for visitation in healthcare settings subject to feasibility. And so there's a lot of discussion going on at the moment with, including consultation with stakeholders about how we do that and how we implement it in line with that issue about feasibility. So we have guidance on visitation various and other access in healthcare settings. And as I say, we are updating that guidance in consultation with the stakeholders that we would normally discuss that kind of guidance with, in terms of making sure that it reflects the needs of people, and it addresses the issue. So we're working on it, I suppose, is what I would say. We're working quite hard on it, but we want to do it right by talking to people and working through the process. And I think that's what was intended by the NPHET decision in terms of looking at the feasibility, is that we would work through the process and get to a position of how we do this in a way that's practical, that works for people, and that there's been appropriate consultation getting there.
Okay, so do you mean it could be quite different to how it's working in hospitality?
Well, I suppose hospitals and hospitality are very different settings. I think one of the issues in that NPHET decision also is the need for exceptions and compassionate grounds, which is part of that NPHET decision. So we need to work that through and to make sure that none of us want to end up in a situation where we want to implement this in a way that is sensitive to the needs of the fact that healthcare settings are very different. And if there are exceptional circumstances around a family member who is perhaps approaching the end of life or whatever, we need to make sure that it's done sensitively, and that's what we're working through.
Okay, thank you. And we were talking there about the antigen test for under 5s. Is there any consideration given to asking HICWA to look at mask wearing for under 12s? Maybe not just in school, but when they're going into the shops and into restaurants, the same as adults.
Is that they've already done that. They updated that in September.
Okay, so there's nothing more since then?
No,
nothing has changed?
It's a substantial updating of the review in September. It was considered by NPHET, and on that basis, no policy change in respect of mask wearing for under 12s was recommended. Yeah.
Okay. And it's not being reconsidered now going forward?
Well, I wouldn't say that it wouldn't be reconsidered, but there isn't an updating of that review underway by HICWA. So that's a very detailed and systematic evaluation of the published evidence. There wouldn't be any significant change in that evidence in such a short interval between now and when that advice was presented to NPHET.
Sorry, September feels like a long time ago. Sorry.
Well, not in the context. Well, it does in some respects. I agree with you
Sorry.
there.
Okay, and then just
but not in the context of the ongoing conduct and updating of systematic reviews.
Okay. And then you were talking about sectors. I don't know if any of you were listening to Joe Duffy this afternoon. There was a lot of people working in the
no
transport.
disrespect to Joe.
Yeah,
but
they were talking about ventilation, and people who work in taxis and use the DART and take buses were saying they're having real problems lately. So I wonder, you had a message for the publicans. Is there any message for like the staff on the DART about windows and things like that? People were quite stressed.
I might ask Professor Nolan just to say a word in more general terms about ventilation, but again, it's all the basic, and we understand, of course, that staff who will and...
Or passengers, actually, sorry,
yeah,
I shouldn't be.
Yeah, that these kinds of environments are environments where the risk of transmission is increased. It's part of the reason why our ongoing advice around mask wearing in public transportation is still really important. The durations that people spend on public transport in close proximity to one another is, in relative terms, short compared to some of the other things that we might do. We might go to the cinema and spend an hour and a half or 2 hours at a movie, go to the pub and spend a couple of hours and so on. So there are differences in terms of the application. I think we still continue to encourage as high a level of compliance as we can on the part of those who are responsible for operating public transport and the basic measures around making sure that the dispensers, the hand cleaners and all of those kinds of things are full and available to people, that the messaging is refreshed and the signs are visible, as well as the continued emphasis around the adherence to the recommendation around mask wearing in those specific circumstances. Do you want to add something?
Just very briefly, I mean, ventilation is important. Let's start with that. It's important that the air in a room or a classroom or a bus or a train is changed at a minimum a couple of times an hour, preferably more. But I do think we also need to get this in perspective. In other words, it's not necessary for the windows of these things to be wide open and the air blasting through. So it's important just to think about yes, this is an airborne virus. It's carried on the air in droplets and aerosols that are exhaled by an infected person. But it's not as if this then spreads out kind of uniformly in the room and the risk is uniform everywhere. The risk remains much higher close up to the person exhaling those droplets and aerosols and diminishes with time. And of course, this is diluted in the volume of the room as well. So if you think of yourself on a bus or a train and the person beside you is symptomatic, is infected, one would hope they wouldn't be there if they were symptomatic. The person beside you is infected. That person is a risk to you, there's no doubt about it. They're probably not much of a risk to somebody who's 5 or 6 meters away on the bus. And the mask wearing on public transport is there to protect you, if you're right beside them, from an asymptomatically infected person beside you. So like, how do we prevent transmissions on public transport? Symptomatic people stay away from the public transport. Asymptomatic people on the public transport wear their masks. And yes, of course, in addition to that, we try and make sure that the bus or the train or the tram is reasonably well ventilated. But that's an additional measure over the other two. And the thing that's offering huge levels of protection from the people immediately around you is the mask wearing. And I think we need to get in perspective the risk of the virus being transmitted over much longer distances, which is a much less common phenomenon and is mitigated by ventilation.
Okay, thank you.
Mark.
Hi, Mark Coughlin from Primetime. You say the force of infection is too high and it needs to come down, and the way that you've hoped it will come down over the last couple of weeks is the kind of cumulative effect of everybody's behaviour changing. And then you told Fergal there that there isn't any evidence to say that the mobility data to say that behaviour has changed. And at the same time, you say you're not going to consider reimposing restrictions or advising restrictions. So is there any reason or data to suggest cases will come down soon?
Well, others might add to this. I'm saying that for now, the question of restrictions is a hypothetical one, and I think we just need to collectively and individually focus on as much as we can on the basics. And without reiterating all of that now and boring you, these are the measures that we think can work. It is true to say, and you're right, that the evidence that we have in terms of, for example, mobility data showing that as yet we're not seeing the kind of pattern of behaviour change that we like, our levels of collective socialisation across all of the age groups, across the whole of society, is at a level that we haven't seen over the course of the pandemic. It's in excess of the level of socialisation, it appears, that we had before the pandemic began, in excess slightly of the level that we saw in the run into Christmas last year. And so I think that we need to concentrate, if you like, on that, because all those measures are still going to be important. Even if one was to, and this is not in our contemplation at this point, to be considering further restrictions or walking back a road that no country wishes to walk back or is planning at this point in time to do. We'll still need as high a level of compliance with these basic public health measures, because it will still be the case, to the extent that we can achieve high levels of compliance with that, the dependence on other things will be less. But the force of infection at the moment, and as Professor de Gascon said, the number of opportunities that the virus has to infect, for example, a vulnerable person is simply too many, and a vulnerable person is exposed to a substantial amount of additional risk because of that level of community infection, even though they're as well protected as they can be with the levels of vaccine, and they might be practicing good and effective behaviours themselves. These levels of community transmission do represent a level of risk that we simply can't regard as something we can live with.
There doesn't seem to be any indication that it's going to change direction anytime soon, is there?
The measures that we're recommending, we think, because we've seen this happen before, have the potential to bring about, but we haven't seen the evidence of that yet. As Professor Nolan said in response to an earlier question, it may well be that factors will arise that will see a change in the pattern of transmission. Over time, if it was to continue to go up, that would happen naturally in any case. But we're not forecasting that that's what's going to happen. And we've no certainty at all that the level of transmission will reduce if these patterns of socialisation continue to increase. And as we get through November, and we're starting to come to a point where, as we get through November, we'll be getting into the Christmas season, I think it's a very risky time for us to be continuing with such high levels of socialisation, given the burden of disease that's in the population at the moment. This level of socialisation might well be something we could deal with if we had a very different pattern of transmission that some other countries have at this point in time. Our pattern of transmission is very high as things now stand. That force of infection very, very high, increasing across all of the age groups, virtually under the age of 75, and driven, as we know, by a very widespread pattern of socialisation. It isn't, as I said at the outset today, that we have collectively just abandoned adherence to public health measures, but there has been a change in terms of our collective, and if we can dial that back a little, by each of us doing our best in terms of compliance with the basic measures, forward planning, understanding risks, staying away from risky environments in particular, the bit that I keep emphasising, if we have symptoms, we need to get out of circulation, whether that's work, school, socialisation, inviting people to our houses, etc. These are the measures that we need to concentrate on. These are the tools that can work. We'll just have to wait and see, as we monitor the effect of the disease and the trends in the disease, is it in fact working? So far, we're waiting to see the evidence of that. The encouraging signs we're seeing in the potential impact of boosters and so on. But the change in terms of socialisation that can affect basic transmission, we've yet to see evidence of.
Just to follow up on that, you're talking about seeing evidence of anticipatory, or we used to call it anticipatory behaviour. We would, as far as I understand from looking at the previous patterns in the data, we would have expected to see that anticipatory behaviour kick in 2 weeks after you began your messaging about being more cautious. So we haven't yet seen that. So my takeaway from what you're telling me is you don't expect to see cases turning anytime soon. And sorry, on your answer just there, you also said that there's a danger heading into Christmas of a high force of infection. Can you expand on that, what your thinking is in that regard?
Well, like at these high levels of transmission, even small changes in our collective socialisation have big effects on the total impact of disease. And obviously, I don't need to tell you, Christmas is a time of the year when, all other things being equal, we tend to socialise more than other times. And to get us into that period of time as low as we possibly can be, and given that it's early November and we're looking at these kinds of numbers, that's going to be a challenge for us. But that's what we would like, to get down as low as we can, as quickly as we can. Can I predict that that's going to happen in the near term? No. It's my expectation that it's going to change in the next week or two, not necessarily high, because I think quite a number of the infections we're going to report in the next 10 to 14 days have already occurred. But we still, so I'm not concluding that we won't see that change, but I think your point is a fair one, that like in the past we have seen people respond to very high levels of cases and change their behaviour and change our collective behaviours as a result of that. There are, within our data in terms of population behaviour, evidences that maybe, at least in some respects, some of those measures aren't getting through, which is why we continue to emphasise the importance of these measures. Philip, do you want to add?
I mean, it's a simple truth that unless the levels of social contact come down and/or we redouble our efforts in terms of mitigating the risk of any contact, case numbers will not come down. And I share the CMO's optimism that, if we message this, if we signal this clearly, that people may well realise that we do have to be really careful about these things, because running along at 3,000, 4,000, 5,000 cases a day every day puts a really substantial cohort of vulnerable people at risk day after day after day after day. And we have a collective obligation to reduce that risk, bring the force of infection to more manageable levels, and that significantly reduces the risk for the vulnerable. And I think added to that, one of the reasons that we're so keen to point out the need for enforcement reminders in a variety of sectors is not only does your COVID pass being checked on entry to a premises, or the rules about wearing your mask on your way to the bathroom, not only does that protect you in the premises, but it acts as a collective reminder. It's still here. We need to observe these measures. These are the things that are keeping us safe. So I think the fundamental message here is twofold. To the public, it is absolutely worth your while to make modest adjustments over the next few weeks to how you go about your daily business. You're free to do almost anything you could want to do, but could we do somewhat less of it, and could we do it more carefully? And to the various sectors, you also have an obligation not only to kind of enforce the rules, so to speak, but to serve as a support and a reminder to everybody that unfortunately, because of a Delta variant and all sorts of other things, we are going to have to stick with some basic, not particularly costly and not particularly restrictive things. And the reason for doing that is the risk to the vulnerable of the very high force of infection that we have at the moment.
Dr. Holden said there that a lot of the cases that you expect to see in the future have already occurred. You said there that you seem to infer that we could be looking at 3,000, 4,000, 5,000 cases a day over the coming period. Is that a fair summary of what you would expect to see?
If nothing changes, I mean
sorry, just to supplement that question, there doesn't seem to be any evidence of anything changing either. So is that what we would expect to see?
Well, put it this way: the cases we're reporting today are infections that probably occurred a week ago, maybe a little bit more. So what's going to happen for the next 10 days is predetermined. But after that, nothing is predetermined. So all we know right now is how the virus was transmitting 10 days ago. And I think that's, so people could have changed their behavior over the last week. They could change their behaviour over the coming week. And I don't like using that word behaviour, but I think the fundamental message here is, sure, I mean, we've done this before, we're tired, but it is, and it's harder because we've done it before and we're tired. But it's our job to clearly message the necessity and we have to remain optimistic that people will hear that message.
Great.
Thanks, Mark.
Hello, Craig Hughes from the Irish Daily Mail. Dr. Hoolan, would it be a fair assessment of the comments today to say that you singled out under 30s as being an at-risk group due to the high levels of unvaccinated in that population, relative to other populations? And Professor Cormac has asked people, to avoid crowded indoor places. I mean, is the message really for younger people to avoid nightclubs then?
No, not necessarily. I mean, and it's not. We're not singling out but what I might regard, let's say, vaccination as something extra that, if you're in that age group, that you might consider, because 1 in 5 people in that age group have yet to have the benefit of vaccination, and those benefits we've talked about, and they're extensive. But the message in terms of the behaviours and the adherence to the public health advice and so on is a message across the entire population, because we are seeing socialisation across the entire population. It's not just, this isn't young people going to nightclubs. Of course, that's part of the pattern of socialisation that we're now experiencing, but that's not the explanation for everything that we're seeing. But we're seeing transmission now happening at an increasing rate across all of the age groups, certainly under the age of 75. Everybody, irrespective of what age band you belong to, has to think about the kinds of measures that they can take, the activities that they're undertaking, and be mindful about, let's say, the kinds of activities they undertake, particularly when they're higher risk activities. So a nightclub is a higher risk activity. Being at a large gathering indoors of any kind, particularly if there isn't ventilation and good adherence to measures, and that can often happen in households and in other informal settings. These are high-risk situations, and to understand and recognise that. And if we individually are night after night engaging in high-risk activities, that carries a certain risk profile. But if individually we decide we're going to undertake a relatively speaking higher-risk activity, we need to follow that up with, let's say, lower-risk activities. I'm planning to go to a concert in the not terribly distant future. I won't be more specific than that. That's relatively speaking a higher risk activity than other things that I might otherwise intend to do. I expect the environment will deal with those kinds of risks and put protective measures in place. But it's not as safe as staying at home. But I'm going to undertake that. But I won't be going to concerts 7 nights in a row. So it's that kind of thinking that I think we all need to.
I think people might wonder, what is a safe amount of time to go to a nightclub? Is it once a month? What you're recommending is once a week not acceptable? Because I just think people find it a bit hard to say, don't engage in high risk activity, avoid crowded places. People might say, well, if I go to a nightclub, how can I avoid being in a crowded environment? You can't. So what is an acceptable level?
Maybe things have changed since my day, but I would have thought going to a nightclub once a week was quite an amount of night clubbing, but others might have a different view. But certainly, if we think in terms of the incubation period, the likely incubation period of this virus, it's if you're not going to nightclubs more frequently than once every 10 days or once a fortnight, in terms of transmission, you're likely to that would make sense. But going to nightclubs every second or third night, if that's something that, and there may well be people who do that and want to do that, and that would constitute probably too high a level of, and you're mixing with a lot of other people in those kinds of environments.
I might ask you on the boosters. Can I just get a sense of what the thinking would be from a NIAC perspective of why not to extend that beyond where we are currently in terms of why would it not be for everyone who's been vaccinated after they've had their second vaccination 6 months on? What's the thinking there in terms of not doing that? I know obviously there's a larger policy decision to be made by CMO and the minister in terms of whether that's ethical or whether it should go ahead. But just purely from an NIAC perspective, why wouldn't we progress with extending boosters further?
I suppose I'm not necessarily here representing NIAC today. So I think NIAC receives requests from the department to look at various considerations and continues to review the evidence around all of those. So probably, there's ongoing discussions and evidence reviews at NIAC across a range of areas in relation to vaccinations or vaccines and boosting. But I don't think it will be helpful for me necessarily, is that I'm not here representing NIAC today. I'm more here as a jobbing virologist.
I know, but I mean, you do sit on NIAC.
I do, yeah.
People are trying to understand, why it was so slow, for example, for healthcare workers to be approved. Could you just give us like an insight into the thought process there and what the delays would be in those decisions being made?
Yes, I suppose, yeah, certainly decisions that have already been made. I would probably disagree slightly with the contention that it was slow, but I'll take that on board. There are a couple of issues, I suppose, when you're starting out a vaccination program, what you're trying to achieve. So obviously people will remember we first wanted to protect the vulnerable. That was one of our first issues, to protect the health service and to minimise harm. And we also wanted to protect the individual, and that's why we went through the population with the initial course. So the question in relation to boosting then is what you're trying to achieve. So the first step is to try and protect the vulnerable, which we have done at an individual level. And then the second question is trying to minimise harm. And if you're looking purely at a cohort of healthcare workers based on their age and their underlying health conditions, individually they're probably not at increased risk of severe disease and therefore don't necessarily need a booster from an individual perspective. However, from a point of view, from a societal perspective, and to minimise harm and to protect the vulnerable and to protect the patients in the health service, and you could argue to protect the health service as a whole over the coming winter, then that's a justifiable decision to administer boosters for that reason. And I suppose that was really, that would have been one of the, I suppose that would probably be the crux of the discussion we would have had over recent weeks, because from a global equity perspective, a huge proportion of healthcare workers around the world haven't had a single dose of vaccine yet. So we have to take all of those things into account. And I think, yeah, that's probably, it was never about not wanting to vaccinate the healthcare workers. It was always about what are we trying to achieve by vaccinating the healthcare workers, and does it fit into our ethical framework, which was established in conjunction with the department at the very start of the vaccination programme. And unfortunately, notwithstanding a lot of the commentary, they're not straightforward decisions in many respects. There are a lot of considerations that we have to take into account, and we also have to look at the evidence, which frequently is coming, I suppose, from different jurisdictions, because they've moved more quickly than us, and they've larger populations than us, or they've used different vaccines. So there are lots of different considerations. But yeah, I suppose they were the things that we put into that, and I think we've come up with the right decision. And hopefully healthcare workers will avail of that in the next couple of weeks as the programme starts.
Could I just add something which I've said before, Craig, and it's not necessarily suggesting that it's not a fair question, but the premise that there's a delay here and so on, in fairness to NIAC, I mean, it is a complicated process. I'm not a member of NIAC, so I'm not party to the actual detailed deliberations that happen, but we do receive the advice and understand the importance of having a group of experts led by Professor Butler. And given the time and space, the owner's responsibility of assessing that evidence and advice and advising on what needs to happen. And we have changed course on many occasions in response to that evidence, whether the evidence is in relation to the impact of the disease on occasions, or of the vaccines, I should say, and on occasions it's also been in relation to safety data that might have arisen. That's led to changes in the advice and guidance over the course of the entire pandemic. And it's that careful consideration of which does require time, and sometimes that isn't as well understood by people who should understand that and the importance of that, is part of the reason why the public has had such a high level of both trust and confidence in the advice ultimately that's based on NIAC advice about who should receive vaccine. Of course there's an impatience around, but the net position we're in, we have achieved in this country a very, very significant level of vaccination. We continue to point out the areas where we can improve further in terms of uptake, for example, among the 1 in 5 of the 18 to 30s who are yet to be vaccinated, for example. And we'll continue to advise in relation to that. But NIAC has taken its responsibility seriously, and it's been a key plank and part of why we have such high levels of vaccination in the country. And relative to where other countries are at in terms of booster programs, our implementation of this is not delayed. There's no side-by-side comparison that will suggest that, it could be regarded that we've delayed on the implementation of other measures in comparison to other countries.
And just finally, is there a date for the next NPHET meeting and any indication of being brought forward if cases keep rising?
The date is scheduled to be tomorrow week.
And will there be, can you see any circumstances?
No, at the moment we're planning on the basis of NPHET taking place next Thursday, the 11th. Okay. The 11th? Next Thursday, yeah.
Okay. Thank you very much.
Thanks.
Just
Thanks
one
very
more
much.
question, sorry. This
Sorry.
might have been asked while I was out of the room. I'm just wondering, what is the percentage of new confirmed cases that you expect will translate into hospitalisation at this current point in time?
Well, we were, over the last couple of weeks, looking at about 35 admissions to hospital per 1,000 cases, so 3.5%. That has dropped a little bit, as I say, because I think the age mix of cases might be shifting. So I don't want to make a projection forward to say every 1,000 cases we have now will translate into 35 admissions. But even if you look at today's numbers, 7-day average, 2,660 admissions to hospital. So we're not far off that kind of ratio at the moment, and that is a concern.
Thank you.
Thanks, Sarah. Thanks, Eva.